Well, thank you all for being here. We had the privilege of having a sort of pre-meeting call, and I was really excited by the exchange we had on that call. And maybe we could just start and go down the row here with introductions. And everyone in the audience has a program, but if you briefly introduce yourself and give us a little bit about your background. And then after we do the introductions, I'm going to ask each of you to share one thing that you've worked on and one thing that you hope for in the future related to making EHRs perform better for patients.
Sure. So thank you for the opportunity to be here. I'm Jenny Schneider, and I am the president at Livongo Health. Livongo Health is a technology company that's really working to empower people with chronic conditions to live better and healthier lives. My background and training, I'm an internal medicine doc, did med school at Johns Hopkins, did my residency here at Stanford, served as chief resident, and then stayed around and did a master's in health services research. And then I entered into the technology kind of startup world, first at a company called Castlight Health, making cost and quality transparency important to members, and then transitioning over to Livongo, where I've been for 4 years.
Hi, I'm Bill Hagan, and I work for UnitedHealthcare. I'm the president of UnitedHealthcare Clinical Services, which oversees our utilization management, care management, and ACO operations. I've been with UnitedHealthcare about 20 years nearly, and operated in various organizations in Medicaid, in Medicare. I ran our National STARS program, and also today oversee our 3 lines of business, which includes commercial. And I'm not a physician. I basically came up through the operations ranks, ran health plans, regions, and that's a little bit about me.
Thanks.
Hi, good morning. First, I want to thank Dean Miner for being proactive and solutions-oriented in what is such an important arena right now in healthcare. I'm Dr. Vanila Singh. I am a clinical associate professor here at Stanford. I've also just recently served as the chief medical officer in the U.S. Department of Health and Human Services. I also finished chairing the opioid pain task force. As you know, that's a very important endeavor going on in our nation. And I'm also proud to say I'm back to seeing patients as well as other endeavors. I have a background in molecular and cell biology as well as economics. And I am very passionate about patient-centered medicine. I think we are definitely on the cusp of hopefully improving patient engagement for better outcomes.
Thanks. I'm Harlan Krumholz. I'm a cardiologist and professor of medicine at Yale. I direct the Center for Outcomes Research and Evaluation, and I'm a founder of Hugo, which is a platform that is intended to give people agency over their healthcare data, to make it easy for them to acquire it, have it organized and harmonized, and position them to be partners in research or their clinical care, and with the presumption that we have to abandon a lot of the paternalism that we've inherited in our profession and understand the rights, roles, and our responsibilities to our patients in ways that we weren't exactly trained in. And it's not just about us gaining solutions or what we can do with data to make us better doctors, but it's how we can work collaboratively and to strengthen the relationships that we have with our patients, respect and honor their participation and their wisdom about themselves, and to give them the opportunity to gain access to their data and then provide opportunities for that data to be used in ways that can help them or may help the people that follow them.
Great, thank you. Jenny, could we start with you? One thing you've done in the past, and then one thing that you hope for in the future that would benefit our patients with regard to interacting with EHRs?
Yeah, it's a great question. So I'm going to preface this by saying that our executive chairman started and ran Allscripts, and our current CEO is the president of Cerner. So in our company, we have deep historical knowledge of electronic health records. The fundamental premise of what we've designed and what we've built is, I think, very similar to Dr. Krumholz, is that we believe that individual people have the right to access their data. And in this world of health care, there is more and more data happening in the ecosystem, independent of us as physicians. And so one of the things that we have built at Livongo is to put we call them members, but to put the patient at the center of all of that healthcare and allow them to distribute that in a protected environment to whomever they want on their care team. recognizing that for people with chronic conditions, the data is typically, or the biggest influencer is not their doc, right? That's who's writing the prescription, but it's their family serving meals, et cetera. So one of the things that we've done in regards to electronic health records is we've integrated that real-time blood glucose, real-time blood pressure, real-time weight data into electronic health records. We've had great success through Allscripts, through Cerner, given some of our leadership, eClinicalWorks, Athena Health. There's a big one, noticeable, that is not on the list that we've not been able to integrate with, but we've been able to provide that data directly back into electronic health records to allow physicians to see real-time data, again with this premise that the individual person is really in control of their data. And so I think moving forward, I think there's a tension between the amount of data that we as people are collecting that impact our health in the real world and the amount of data that lives in the electronic health record that's available and useful for physicians. And so I think what I would love to see is, again, a little bit more of that unification, and not just streams of data, but algorithms around to help make decision support, both for the individual people, patients, and then for the providers.
Thank you. Bill?
Good. Wow, one thing. I guess I'd just like to start with, I think for all of this to be possible, we have to have standards and interoperability. So one of the things that we are doing is one of the persons in our group is the chair of the Da Vinci committee, which is setting the standards, and both for for each of the transactions that are required to be supported in order to share information across the continuum. So I think for me, it does start with standards and sponsorship of those standards. In terms of things that we're doing, I see a continuum of things. One, the individual health record is really key to foundational doing anything foundational with patients and with providers. And you think about patients having their information. I do remember the days where I had to carry my images around and go to the next doctor and bring all my images. And that wasn't that long ago. And so really having the portability of the individual health record, and that to be comprehensive, including social determinants and every other factor that we could build into that record. But as you say, it doesn't really stop there. The next thing that we have that incorporates that is really the use of digital health, and to be able to use remote patient monitoring and wearables and incorporate that information. And then finally, to make that information available at point of care. We've developed a number of applications around them. One of them is we call it Pre-Check My Script, that allows you to go in before you get your medication. There's price transparency for the consumer to allow them to select an equivalent drug. And we, to date, past year, we have about 25 million transactions that we've executed at point of care. And we see the evolution of providing that information in that three-way mechanism between the health plan, the consumer, and the provider, so we can get that engagement with that information in an actionable way.
Great. So thanks for that. I just want to say that until now in my entire career, from the clinical perspective, it's been about encouraging patient engagement, whether it was with EHRs or paper records in the past. We know that patient engagement leads to better outcomes, it's better care. In this era right now, it's about really reassuring the patient that, one, their data will be protected and private. What I saw the last couple of years in the US Department of Health and Human Services, many of our patients were concerned about putting sensitive data in their EHRs. When you think about potential substance use or mental health issues, that's a big concern. It's a good example of why there may be reluctance for those who can. Certainly easing the platform is a vital issue for folks who may be interested but are, like all of us, limited on time and don't want to have glitches. So I think there are a lot of folks in this audience that I've already met who are working on that, and I have great optimism in that area. And finally, incentivizing folks. This is something that we also saw that if they do invest the time into their data, into the portal, and engage, that in fact, there will be outcomes that either are clinical or that they see immediate in terms of that investment into the EHRs. So I just see it as easing the concerns, the platform, and incentivizing. This is something that I feel we've always done, whether it was paper records, but now more than ever, there is a lot of means that patients can take to really improve their own outcomes and feel like they're very much a part of the therapeutic alliance.
Well, let me get back to what I was talking about before, which is I'm very proud of building a platform that enables people to acquire and organize their data with the commitment that no data is going to move without their permission. Look, I think we've got a problem, and the problem is not just technical. It's not just a matter of code. This is cultural. So what is the current situation? The situation is that large, I call them data oligarchs, are holding 400 or 500 million records that they're linking. They're linking to behavior. There was a big Veradigm and Komodo just announced that they've now got a database with 50 million patients that's linked with their behaviors, their prescriptions, their medical data across time, across venue. I don't actually know where it is. I don't know where it came from. I don't know if I'm in it. And I don't. And you don't know if yours, I'll ask anyone here, do you know if your data's in that's being linked with your behaviors, with your clinical? Oh, by the way, it's de-identified. It's de-identified. So your unique phenotype of your behaviors, your clinical experience, your meds, what you've done, all of that linkage was somehow done without ever identifying you. It's a remarkable miracle. But I want to juxtapose that to what you've heard, which is that, so meanwhile, people are worried about the security, but through business associate agreements, every healthcare system in the country is leaking their records out to third parties who are de-identifying it and then selling it to other data oligarchs who are commercializing it. Every single health system is doing that. So we talk about security of these new companies. Oh, I'm afraid to give people agency over their data. People are saying don't do it because people will take their data. But every healthcare system is already leaking all of the EHR data every day. Our institution, you're a cancer patient, the entire record identified is sent to Flatiron every day. I meant Roche every day, which is at Flatiron. The juxtaposition to that is try to get your health records. Try it. I took a medical student and we did a secret shopper study where we said, pretend like you're getting records on behalf of your grandmother. Call the U.S. News and World Report, don't believe in that anyway, but U.S. News and World Report, top 50 hospitals, and see how easy it is to get it. It was a maze. People didn't even know the facts. They kept telling her, sorry, we can't help your grandmother get her records because that would be a HIPAA violation. She said, can I do email? Someplace wanted to charge $500, a lot of it in violation of the law. So this juxtaposition is the problem. You asked me what I'm proud of having created a platform that enables it. Healthcare systems itself aren't even letting people have all their data. The law states clearly, you are entitled to all of your records, including images. By the way, you said to me, you remember when you went around with images? My patients, yeah, that was yesterday. Yeah. On CDs, and no one's even got a CD player anymore. That's what you get at our place. I'm surprised we don't give them 8 tracks. So what you've got is a situation where nobody can get the records. At my place, we're still arguing. God bless at my place. We signed up for My Open Notes. We're giving people outpatient notes. We're still debating whether we can give them discharge summaries. By the way, all in violation of the law, as Stanford is and as every other medical center is, not in full compliance with the law, which you know. And so, I know there's a long response. This is what I'm proud of having created a platform. I'm telling you, it's not just a technology problem. It's cultural. And we've got to stand up and say people have a right to their data.
Responses to that? Culture.
I was just going to say, I agree. I mean, it is sad when you see that your data, though de-identified, is made available to everyone else. But it's challenging, because we're all patients at the end of the day, right? Whether it's wellness or disease. But it's challenging for us to get our own data, the entire set. So I agree with you. I mean, that's the challenge in that. And when people are concerned about engaging in their portal and their own sensitive information, it's not they're scared of getting it themselves because they already know about their own sensitive information. They know that the risk is to third parties.
And even if your data was among the 50 million, you'd have to pay for it to get access.
Yes, right, to get your own data. So I think that is the challenge, but the irony is like the same way anything is, where we put in our own passwords and we get locked out of our own systems, our own banking, everything. But other people who are really intent and have the means could hack into anything. And also just, here at Stanford, we're so good about ensuring that we understand privacy issues, and we're not using sensitive health information, and we're not going to risk the patient data. But the truth is that there's always a risk that's much greater than what we as clinicians may have in our hands, or any of our staff, that could be hacked or gotten to. And I think ultimately that reassurance to patients is really necessary. And then, of course, we can see that engagement become bigger, because I think most people are very concerned and want to have better health. Most people are incentivized that way, but I think they have to be reassured ultimately.
Well, let me ask this. I think we all accept that we own our financial information, right? And we use ATM machines and things like that. And those are fairly widely embraced, that we perform financial transactions electronically. The apps that are available today for each of us as patients to get access to our records are not as user-friendly by and large as many of the simple apps that we use for financial transactions, but they're also not incomprehensible. And yet the adoption rate of those apps that are available, either through the electronic health record systems or through some of the third parties that are making apps now that give us access to our data, the adoption, or you could even say the insistence of patients to being able to get their data into those apps, has not been all that vibrant. And why do we think that is? And that's my perception, and there's been a little bit of literature on it, not a lot, but Bill, does that resonate? Are people really saying, look, this is my data, I want it, and I want it in a form where I can access it, understand it, and take it to wherever I want to take it?
Well, I'll personalize it, so I would want my own data, yes, and I would want a complete clinical record. Now, I think part of the problem, didn't this happen when Blue Button 1 came out, that they went to access it and somebody got this like pages and pages and pages. It was hundreds of pages of information. And I don't know if you've ever looked at your EOB, which is the basis of Blue Button, but it's like almost indiscernible as to what it says. If you go to a cardiologist, you have one visit, you might get 5 procedures out of that visit. And understanding, oh, well, why do I have these 5 procedures? I just went for one thing. And so I think the complexity of how we record information, and then how that translates to individuals in terms of being able to understand it, I think is one of the barriers. And if we base it solely on clinical terms, it's very difficult for the average individual to understand, well, what's really going on with me. So I think, one of the things that we looked at, and we collect like just a ton of information from health information exchanges and so on, but if you go to a health information exchange and you look at the history of individuals in the health information exchange, it's very complicated. And so I think having an ontology that allows you to rationalize that information, get rid of duplicates, because there's a ton of duplication, I think is one of the keys to how do we make it intelligible to the individual to understand, yet at the same time, when you provide that information to the provider, you provide that information clinically. So I think the strategy as we go forward in sharing information has to be both one that's understandable and comprehensible to the individual non-clinician. At the same time, you want to provide that same information to the clinician. So I think, to me, that's one of the challenges. And related to, sharing information, we just struggle with that too, because, we have a ton of privacy laws. The privacy laws aren't the same in every state. Restriction on what you can share and what you can't share, who you can share with, what requires consent, what doesn't require consent.
You have restrictions on being able to share back with the patient their own data?
Yeah, we have.
Which state restricts that?
With the providers, is what I'm talking about.
No, providers.
Yeah. And so, what you can share is part of the process who you share it with. So, no, not with consumers.
Because you guys are covered entities, so you're required actually to share back with patients, right?
Yeah. So that's what I'd say.
Jenny, Livongo started with a focus on diabetes, and there, of course, there are 1, 2, 3 important things that are being measured: glucose, hemoglobin A1C, and now you're looking at health as an overall picture. And diabetics oftentimes have other diseases, and so it probably gets much more complicated. How are you thinking about your platform as you grow from being focused on diabetes management to the portfolio of health writ large?
Yeah. Well, I'll answer that and then I think tack a little bit onto what Bill said. So for people with chronic conditions, the Venn diagram, and we all know this, but 70% of those of us, and I have diabetes type 1, have hypertension. Another 30% have depression. So there's a big overlap. And so as we're looking to empower people living with chronic conditions, we need to take care of them as a whole person, not address individual conditions.
Correct.
And so in doing that, I think when you have a condition, when you have cancer of a certain subtype variety, you start to understand those clinical words because that is very important to you. So this idea, coming back to, I do think there's a translation around what is the data, but what does it mean, right? And so for those of us with diabetes, you're used to checking your blood glucose level, so you have some sense as to what even the low and the high end are, right? Whereas if you don't have diabetes, you may not even know what numbers to think about, for example, right? And so as we look across multiple chronic conditions, we are doing this service where we're providing the data to individual people, but not just the data, it's the insights around that data that's really helpful. So it's great to know that your blood glucose is 200. It's better to know that 200 is high, even past eating. It's even better to get a message that's going to motivate you to either take some medication, go for a walk, or drink a glass of water. So what then to do with that what then to do with that data? So as we look and expand into other chronic conditions, that fits across the whole person. So if you have diabetes, hypertension, you're overweight, and you're depressed, your blood glucose is 240, it might be that thing you need to do is actually go do de-stress exercise because it's your anxiety that's driving all these other outcomes rather than that one data point. So that's what we've built is this platform to sit across that. But I think as we apply the data back to the individuals, it's the context that matters, as well as the data. So giving people the data, we absolutely believe that. All of our members have access to all of their data. They can share that with whomever they want. They're at the center. But we're giving them context above and beyond just the data points to make it meaningful.
You guys have an API for patients?
Our members can access their data at any point. So I think your question is, do we have an open API? Is that the question?
No, an application program interface for patients to handshake and get their digital data back.
Yeah, so all the time, so our members have access literally on their phone. They have.
No, but is there an API that people can?
We have had a couple incidences where people have asked for that, but it's very, very infrequent that people have asked for that. So, but it's not that we wouldn't for the patient. It's just that the patients aren't coming to ask for that. So it might be a little bit around the cultural issue of people trying to access their data to understand that we would never prevent our members from taking the data to do whatever they want with that. We don't build an open API because we want to make sure that the member's data is protected, right? But if our member wants the data to go somewhere, we've been able to do that.
But it's a blue button. It's a protected API essentially, but I think you guys are great, by the way. I'm not criticizing. I was just asking if you had an API. But I think the current situation, just get back, Lloyd, what you were saying before is, and the article came out of Stanford that said there's been low adoption of these kind of methods. Well, I think of it's like, okay, let's build a bunch of ATMs, see if people use ATMs, but we're going to redact the information you get when you go to your ATM. So, you're going to get some of your bank accounts, some of your transactions. I mean, and people. And we're going to say, let's give up on the ATMs because nobody's using them. And what we need to know is that every bank has got an API that is then when you make a call, that's going to whatever bank you want to, or that you can then have that information organized and ready for you. And then also, I think ultimately there will be a lot of applications. Livongo themselves, you guys might say if people coming with their data, that actually would make us better at helping with the disease management, with your permission. And I think we're at the cusp, the first half of the first inning in baseball playoff terms. But it's like, we are at the moment where the law is clear. If you're a covered entity, then you are required to make available in digital form the data that people want in the format they want at their request for minimum cost. Nobody's doing that now easily, right? And not giving you the whole thing. But as we transition and the law gets strong, 21st century cures is out, the ONC and CMS rules are going to strengthen this. I think we're going to be at a point where we're going to see a very new future fast. And then the question is, how do we protect people, right? How do we help people make wise choices? How do we, like just what we do, how do we help people make wise choices with their money? But I think we're going to flip, and the EHR is going to be one important source. But again, cultural problem, every EHR with a flip of a switch could make all that data available to patients through an API, through the blue button. But FHIR, however we want to do, Josh Mandel's going to talk about FHIR later. But the health systems aren't turning it on. They're not trusting the patients that they can handle their data. They're holding it back. You can go in the basement of our place, pay $200 and get your paper record. You cannot connect through an API, even though the law says you should, in order to get your entire record right now, so that I could tell Livongo, hey, would you be interested in taking a look at my whole record to do a better job at what you're doing, and to supplement what you've done? That won't happen, but that's what I see the future being. People, if I want a second opinion, bang. I can go to Stanford and say, will you take a look at my record? I was just diagnosed with something important. It's a high-stakes decision I have to make. I want to know what Stanford doctors think about this. I want to be able to say in 2 seconds, I want to transfer it to the Stanford doctors. You guys will say within 48 hours, we'll get back to you with an opinion. Maybe you got to come out and see us, maybe you don't. And then that kind of transaction occurs seamlessly on the basis of the patient. You watch how fast health system starts catering to patients when in a term of a dime, I can go ask Stanford what they think. You watch how fast things change when people know that the transparency of seeing notes is going to be in the patient's hands or mistakes corrected. You watch how fast quality improves. Now we just have to find out a way that this doesn't dump on the docs, that the corrections can occur in ways that don't increase burnout, but that we have the systems in place that say we're not afraid of this. What I've heard from a lot of places, we don't want to give patients the charts because they're going to find mistakes, and who in the heck's going to correct those? Well, there's something wrong with that statement, and we got to find the systems that do it.
Maybe, Vanila, at HHS, where do you see what is the role in your view for policy in terms of these types of interoperability challenges that we have? And of course, as Harlan mentioned, there already are relevant policies that are on the books, but where do you think government plays a role, or is there a role for government in pushing interoperability further than we're seeing today?
Yeah, great question. And right now, you see HHS is actually encouraging, number one, interoperability. They've made some measures both at CMS and ONC to actually push that further. And of course, I think that's a no-brainer. We have to do that because you can't have part of the information. I mean, the challenges for both the physicians and the patients is clearly unbearable. So I think that's going to be a very important thing. And how do we do that? Whatever glitches there are, as they remain, and how the government can incentivize their own systems within CMS. There have been challenges with even my eHealth data initiatives. They found that they were in silos, and they've actually brought those together so that even when you're a Medicare patient, your providers can actually see the whole system. So it's correcting their own system internally. And then, of course, all these policies that are made there affect everyone, all entities, and easing that through better regulations, taking aware the glitches so that perhaps the health systems aren't feeling concerns about legal issues on the one hand while having ethical issues on the other hand that actually go against each other. So I think that's actually there. It's very plain. They've come out with that multiple times. I think there was also a contest that they had last year, which really amazing solutions to how do you address EHR issues and improve engagement and decrease burden ultimately, both for the clinicians. And ultimately that really is for the patients as well, because if there is an ease of face-to-face time, then both are better engaged, both are likely to feel like the EHRs are helpful to them, right? Both from the patient and the clinician perspective. So I actually believe sincerely that, in fact, like a symposium like today, at the end of the day, with all these great ideas and concepts and different key stakeholders present, if this results in a pilot program or even a final, perhaps furthering on the white paper, that should be shared with the folks over at ONC and CMS, because ultimately they want to do what works well in the real world. I mean, if it works well at the 40,000-foot policy level but can't translate into better practices, it's all for naught anyway. And they do need help always. That's the input that we give. That's why I was saying to Dean Miner that I think these are very important proactive solutions-oriented efforts that ultimately I've already seen hands-on where they can get plugged in and make a difference. So I hope that helps.
Thank you. Maybe it seems we can all agree that interoperability is not where it should be today. And Harlan, as you've pointed out, there already are clear guidelines, regulations that provide the patient with access to data. It is the patient's data. But if we look forward 3-5 years, access to data and me being able to get my data when I want it in the form that I want it is incredibly important. But also, it's what's going to be done with that data, and how can that data be. And I mentioned in the introduction that still today, the standard electronic health record systems offer very little in the way of feedback or detailed analysis of my health, someone else's health, to either the provider or to the patient. And yet, that could happen. I mean, that's well within the realm of the algorithms that exist, and the challenge is getting the data in a form where it can be queried, and the various techniques that are available through machine learning can have the same impact that they've had in so many other sectors. So maybe if we, and Jenny, if we could start with you, because you have a platform that is set up to bring data together, and what ultimately 5 years from now, what type of feedback, and you alluded to this before, but maybe you go into greater detail, the type of feedback you would like to provide to patients, and then also to providers that patients elect to have access to the data that Livongo is storing. So if we start with you and then go down the row.
Yeah, so I loved how the intro that you gave, because that feels like we should be doing that, we can be doing that. But I would also say, like, we are doing that. Like, people are doing that, not within the electronic health records, but people are outside. This is, again, where I think focusing on electronic health records as the only place where health data is occurring is errant, right? Mm-hmm. There are companies, smart patients like me, that are startups where people are connecting, they're sharing their data with other people and getting, connections on, like, best outcomes, right? Now, again, you may say, should that be regulated? Should there be some healthcare oversight? Maybe is the answer that I would come back with. We are doing something very similar for our members, which is to say we're getting real-time data, cellular connectivity, so we don't miss any data, and we're constantly looking at the messages that we're giving to people and seeing, does that actually change the next set of data? So when your blood glucose is high, and I mentioned that you should take your dog for a walk, does that actually change the outcome? And so we're seeing that, and that may work in women in the Pac Northwest and not men in the Southeast corner, right? We're starting to understand that by looking at across different components of data. I think the opportunity is to do that more broadly across the healthcare ecosystem, right? And to involve providers who have, basically prescription powers and a lot of knowledge to enact that. But it is happening. That is happening. It's not happening in electronic health records. It is happening today outside.
Bill?
Yeah, I would say certainly the problem of individuals not having their health records is key, because, it's critical. But a second challenge that I really see is we have so many different systems, different providers, and actually members or patients or consumers make their way through the continuum of care, and the sharing across the continuum of care is very, very limited. What we are doing is, certainly we have very large databases like we take in remote patient monitoring information real time, provide that, and if you think about how that's being provisioned back, it's not being provisioned back through an EHR. it's being provisioned back through watches, through other digital devices that you supply out, scales, telehealth. So those are all like really rapidly expanding in the marketplace, the types of devices you can use. Hospital at home is coming to prominence, SNF at home, intensive care at home. All those things are emerging to manage patients in different lower cost settings. And so having the technology and information to be able to do that is really key. And obviously that goes outside of the EHR itself. I think when I think about what at least the next concepts would be in terms of at least what we're doing is when you think about personalization and navigation, it gets down to an individual level. And today we have the technology not to have condition-based treatment at a population level, but really at an individual level. So once you create care pathways by condition, COPD, asthma, and CHF and diabetes, typically those things go together. And really the idea is at the individual level, how can you pull those pathways together, share those pathways both with the consumer to engage the consumer, at the same time engaging the provider in their EMR, because they're not going to come out of their workflow. So you need to be able to be interoperable with the provider in their EMR. At the same time, have these remote monitoring devices and telehealth units, tablets, whatever you can share with information. So I see, and we own Optum Care, like a very large physician group, Apple Care here in California, Monarch, et cetera. Those are our physician groups. So we see the challenge of the EMR and what does exist in EMR. And I liked your comment that you said, in your talk at the beginning is, how can we get treatment decision support, to the provider? And so when I think about, what we can do with the aggregation of information, real-time information, particularly device information, then what we can do with that and farm that out. Then when you get to the provider is what is the next best action or treatment for that, and how could we develop treatment protocols and clinical pathways that could be shared ubiquitously across the continuum. And so I think what's the future for us is leveraging big data to collect all that information, leveraging wearable information and device information with real patient monitoring, telehealth, and then providing in a chronic care hub, for example, with a provider or set of providers to be able to action treatment for that individual.
I would just state that I think we are on a very unprecedented cusp of being able to address chronic, challenging conditions. When we look at single disease entities, nothing comes easily gift wrapped as, hey, you have this one diagnosis and this is kind of how the textbooks are and algorithms are based on that. But the truth is patients have comorbidities. Jenny mentioned that with the context of the data, that really matters. Ultimately, I think what we should have a goal for is that in those patients, which is most patients, have more than one disease entity and a potential set of things that we could address in terms of social determinants of health, behavioral health, and such. And so I would just put forth that the data be utilized as an individualized, personalized, more precision care, because big data is important because it gives us an idea of patterns and clusters, and where as a nation, perhaps, or as a city, county, we can put resources, but ultimately to really make that change tangible to the patient, which is really what we're talking about, patient engagement, as well as the physician and other clinicians, is to make it about individualized care. And the data that we're talking about, whether it's from a mobile app or it's from online portal engagement and face-to-face engagement, that has to come together and tangibly result in better clinical outcomes. I think we are on that cusp. We are seeing that in terms of all these very interesting apps. We see it with the fitness apps, but we're also seeing it with validated e-mobile apps for substance abuse or mental health conditions. And I really put an emphasis on that, particularly the mental health and behavioral health, because that's actually what we're finding is going to impact from the patient's perspective, things that they can do, disease entities like hypertension, obesity, diabetes, and other chronic, even more complex neurological conditions that we see all the time. I certainly am in pain medicine seeing patients who have perhaps lupus, anxiety, depression, hypertension, and maybe obesity issues. And it's never clean, but when the data comes and I see a patient well engaged, whether it is a binder, but hopefully it's more moving towards digital care and data, that is when I know we can actually move towards a very positive intervention. And oftentimes it comes from the patient themselves when they're engaged. I would just say that that's really got to remain our goal, is that we not only see it for the single disease entities that we've started the process on, because we're in infancy, right? You said the half of the first inning, but that as we move forward in this digital age, we are really applying it to patients who have the chronic complex conditions, which is where it really matters and translates into bigger changes.
Well, I like to begin with what the big problem is, and there are many problems here, but one of the biggest problems is that the medical scientific enterprise is currently configured, is inadequate to keep up with the information needs of patients and clinicians and policymakers and administrators. I mean, we are not producing knowledge at the pace that we need. The studies are too slow, they're too expensive, they're too often narrow in scope. They very often don't relate to the patient in front of you, in part because the studies bring in people who are less complex, because that's a testing of a single proof point within the scientific study. And so the result is we end up mounting large $100 million studies to do a single experiment that produces an average result that is underpowered and poorly designed to answer any other question. Any other question within that study is intended to be a hypothesis generator and exploratory by nature. So you end up spending a decade creating a single experiment to produce an average result. I think we all know that what we want is a system that's learning faster, that provides us more information about the people in front of them. What Nigam is doing here, being able to take a patient and say who is like that patient, and Nigam Shah here is great. And this is where we're drifting. We're trying to tack towards this real world evidence. And what I often say, look, Amazon learns with every click, Tesla with every mile, Google with every search. You do a search on Google, you do a search 5 minutes later, it's a different search. There may be an imperceptible change to you, but they are updating that algorithm in real time. And in real time, it gets better. When we're estimating risk for atrial fibrillation, we're hearkening back to a study done a decade ago in the UK with 3,000 patients. With 3,000 patients, and we don't even recalibrate it. We have a heuristic. If you've got more than 2 points on the CHADS-VAS score, then you should be anticoagulated. It's insane. And we're going to give you a point if you've got hypertension and a point if you've got heart failure, no matter what your hypertension is, how severe, diet-controlled, or severe hypertension. We say you can only use the amount of factors that are on your hands in case we have nuclear Armageddon and there's no electricity left, or you live in California and there's no electricity left. That's what the state of where we are. So we have to create a true learning health system. Every single person who comes through contributes to a collective wisdom. That wisdom is able to be tapped by patients and clinicians who can jointly understand the options and opportunities, and that decisions are made in partnership. And so the idea of the EHR, I think, is that the good news is all the data is digitized. The challenge is now how do we actually leverage it, and that's where we're going.
Great. Well, this has been a provocative discussion. Why don't we see if there are questions from the audience? We may not have microphones, but if you speak up, I'll repeat the question, and then if you want to direct it to one panelist, that's fine, or to all panelists. Yes?
Hi, Sherry Duval, or single points of treatment with single diagnoses. So my question for you, Dr. Krumholz, is who pays for large, multi-disease studies? And then just the other comment to Vanila and the others is that FHIR isn't ready for these complex patients, which is the standard for APIs, which we have to have for mobile. So who's going to lead the charge on that? 2 questions, sorry.
Well, let me just say, look, it's not dependent on FHIR. We have the technology now. We can integrate data across data sources. FHIR's going to be better.
Documents, though.
No, we can integrate digital data well. It's a misnomer to say that we can't actually map. We need to get better common data models that will do better job than something like OMOP. We need OMOP clinical. We need to be able to progress, but it's a cultural, what's holding us back is more cultural than anything else. And I think the prospect of where's the ROI on this? How are we going to justify the investment? Well, our past approach is research world's over here and clinical world's over here. They don't actually talk. They don't really understand each other. They're suspicious of each other's motives. They have different reward systems. And you invest tons over here in the research side, and the clinical side doesn't really see the relevance of a lot that's being produced. The future is full integration. The effort that's made to produce the clinical care is producing data that can be generated that can help in the disease management side and on a whole range of different things. And we're able to get more refined phenotyping. We're able to look at people who are like you. And it's not about saying we need to spend $1 billion on a single research experiment, but we can do experiments within this. The tech industry is doing A/B testing all the time. There was a nice article by Leora Horwitz in New England Journal of Medicine about a week ago about how NYU is trying to incorporate this kind of approach into their care. We've got to start thinking differently about how we do things. As long as we say we're stuck in our old ways of thinking, and now how do you retrofit these new capabilities into it, we'll never get there. It's a matter of us thinking differently about how, with the efforts we're already making, which are considerable, how does that feed into a knowledge generation system, and then creating the interfaces so that's available for decision support. Bill said, beautiful, I totally agree with you. So that, and that kind of decision support's available both to support self-care by patients and by the kind of conferences that patients and doctors have as they review what the options are that are available to them. But I think we can do this. It's going to drive down the cost of knowledge generation, and it's going to make it a fundamental property of our system that we're generating knowledge by each patient rather than something that we have to create siloed separate in order to feed into the system.
Can I just add that it's not just research and clinical, but it's policy, because when there's this other arm to all that's going on that is actually affecting it and makes legal restrictions, they're not in concert. So ultimately, it's easy for us to say this all has to happen, but policy has to support it by either deregulating, unleashing, allowing, and the balance being safeguards. Ultimately, right now, if we fully go full throttle, we know our institutions are at legal risk and peril. We know our physicians are. I mean, we get these modules that ultimately scare the heck out of you, and you're like, I don't want to do anything, but you need to. So we can't have this go, stay back, like philosophy, and I think that hinders folks because ultimately we feel like we're going to be legally responsible. So I think that has to all be in line with each other. That's all that I would add.
Are you talking about the decision support tools?
I would say, yeah, I would say
Not
that.
about the data going back to patients, but the decision support tools.
Yeah, I mean, I think that's part of it, yeah.
Yeah, I mean, I would say there is a challenge with legal and decision support tools.
Yeah,
I
agreed.
mean,
Yeah.
and the whole FDA certification, it's complicated. And what you can do and what you can't do is really in the infancy on the legal side. And
But also, it's not just legal, it's patient safety side. I mean, my place has bought decision support tools that have never had an external validation and then put it into the EHR. So I think...
Oh, no, it's obviously caused
patient
because
safety.
of that. Yeah,
Yes.
clearly.
We have another question. Yes.
Thank you. I might be dated in terms of what I know about electronic health records, but when I was looking at them several years ago, they focused on tabular data, meaning tables where you check off things, very quick entry, but hard to see the forest for the trees, and page images. So there's missing a middle ground of what used to happen in medical charts where a doctor would succinctly describe the context and the proposal, the hypothesis, essentially. There's place for it in, say, an Epic type system, where they even have macros to introduce what that doctor thinks of as a controlled vocabulary, but the structure is instantly lost. You introduce the macro, it's just a way of quickly typing something. There's no controlled vocabulary, and all that data is hard to harvest by data scientists. I'm asking, what do you see as the future? Because I see that as the most important data for non-routine patients, and people are talking about chronic problems. Those are probably non-routine. There's no, you have this, you do that.
Yeah. Bill, maybe you could get us started with that one.
Yeah, sure. So you're right. I mean, the basic EHR is pretty basic. However, for example, I met with a large vendor, I think about a week ago, and when you think about whether Cerner or Epic or ECW or Veradigm, pick your vendor, where they are going is where what you're talking about. When you think about how is technology expanding on external platforms to EHRs, and then how the EHR vendors are expanding to be inclusive of that, you see a convergence. And I think it should be interesting to see who owns that domain in the end of those platforms, because each EMR vendor, like the one I was meeting with, of course, it wants to expand the capabilities, which should be actually more universal to every EHR. And and they're expanding databases and so on. But when you think of the universality of what you'd want to achieve in a marketplace, it's not just limited to one EHR. So I think that, and even in our own, Optum Care, we have capabilities that we are building outside of the EHR in order to do treatment decision support, and bringing other capabilities with CDS hooks and other capabilities into the EMR, so that everything can be done at point of care, but doesn't have to literally be integrated into the one tool itself. So I agree with you. That's my perspective, and we're going to continue to see, I think, in the marketplace, this struggle between what's outside, what's inside, what's in the middle, that vendors are rapidly trying to develop.
Well, lightning round finish up. Then if there's one take-home message, maybe we go down the road, starting with you, Jenny. Looking forward 5 years from now, what would be your hope for what patients would be able to do, access, learn from then that we can't today?
Well, I think I share a belief that the patients, it's their data. They have the right to the data. And I may be wrong, but my hunch is that the solution is going to come from the patients rather from the EHR vendors, that it's happening today, that patients know and want their data, and so they're figuring out ways to make that happen.
Thank you. Bill?
I think the cornerstone of anything has to be the individual health record. So I completely agree with that. I think if I were to think 5 years from now, and probably less than 5 years from now, individualized, personalized treatment driven to the patient by digital technology, linked into the EMRs real time at point of care, will be how the system could come to better together. Because the biggest pressure we face is not having an IHR record. Actually, the biggest challenge we face is the cost trends that are occurring in healthcare. And if we don't address the cost trends in healthcare with better organized systems of care, better enablement for providers, better engagement from members, we won't be able to tackle the costs that we are seeing in the countries. And it's a huge problem. So that's where the system will go.
I would say that the most important thing is patient-centered medicine, and that everything we do, all our efforts through technology, whether it's research or clinical practice, translates to better clinical outcomes. If it does not translate, it is wasted energy and effort. And that translation has to be felt by the patient to get their patient engagement. So I would stay focused on that, heed that EHRs, as they probably are doing now, I hope, are also looking at it from the physician perspective to reduce clinical administrative burden, the same way perhaps look at it from the patient perspective so that they can feed you where the right way to go is.
I believe people will have agency over their data. It'll be a powerful force to help us learn more quickly how to help each of them and how to help those that follow them. Here's my hope. 10 people in this room will make fundamental contributions that will accelerate our progress in that direction. I don't know which 10 of you are, but that there are 10 people in this room that are going to make a difference because they were here today.
Great. Well, let's thank our panelists.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.